Welcome to the deep dive. Today we're really zeroing in on a specific challenge within vascular surgery, how to surgically manage lymphedema.
That's right. And we're using Section 25 of Rutherford's Vascular Surgery and Endovascular Therapy, specifically chapters 167 to 169 as our guide.
Exactly. So think of this as, well, your mission, should you choose to accept it, is to get a solid, practical understanding of the surgical approaches laid out in Rutherford's, a focused guide for vascular surgeons.
We want to get into the why and how behind the surgery for lymphedema. Who's the right patient? How do you plan it meticulously? What are the different techniques?
Both reconstructive and excisional.
Yes, and even touching on those primary chylous disorders when they need surgery. It's all based on what Rutherford's presents as best practice.
Okay, great. So before we dive deep into the surgery itself, let's quickly define lymphedema again, just the basics.
Sure. So in simple terms, lymphedema is this progressive buildup. You get protein-rich fluid accumulating in the interstitial space, basically because the lymphatic system isn't draining properly.
And this can be primary, like a congenital issue, or secondary, acquired later.
Exactly. Could be either. And while it technically can affect internal organs, what surgeons mostly encounter, and what we're focusing on, is the swelling in arms or legs, extremity edema.
Right. And why are these specific chapters in Rutherford so important for surgeons dealing with this?
Well, they're structured almost like a practical instruction manual. They take you step by step through the whole process.
So from patient selection,
Through preoperative planning, the nuts and bolts of the surgical techniques themselves, and even managing related conditions. It's very clinically focused, very practical for a surgeon.
okay, so let's set the stage. Before we get to today's microsurgery and advanced techniques, what did the early surgical history look like? What were the first attempts?
Well, the initial approaches were quite aggressive, really radical, actually. Think of the Charles procedure.
Right, that involved removing pretty much all the skin and subcutaneous tissue.
Yeah, and then skin grafting. It did reduce volume, sometimes significantly, but the long-term problems were, well, significant too. Things like hyperkeratosis, really thick skin, and chronic ulcerations in the grafts.
Not ideal outcomes.
Not at all. It kind of showed that just taking away tissue wasn't the whole answer, which eventually led to thinking about less invasive things like liposuction. And later, liposuction combined with compression proved pretty effective for volume, but that came later.
And were there early attempts to fix the flow problem, not just remove tissue?
Yes, there were. Functional procedures, they were called. Things like the Lanz, Condolian, Thompson operations. The idea was to try and divert lymph flow from the superficial tissues to deeper layers by cutting out strips of fascia.
How successful were those?
Limited, really. The big game changer was microsurgery, though interestingly, at first people thought actually connecting lymphatic vessels, doing an anastomosis, was impossible. They're just so tiny. It took some real pioneering work to show it could be done.
Right.
And that really shifted the focus towards direct lymphatic reconstruction, trying to actually fix the plumbing, not just manage the leak.
That's a fascinating evolution. Okay, fast forward to today. A surgeon is considering surgery. What's the absolute first step in planning, according to Rutherford's?
Visualizing the lymphatics, you have to see what you're dealing with. And the ways we do that have changed a lot.
So what did they use initially?
Initially, there was direct contrast lymphography, the Kinmonth procedure, injecting contrast right into the lymph vessels.
That sounds invasive.
It is, and while it gave us our first real anatomical look at the system, it can actually worsen the lymphedema sometimes. So its use now is very limited, really only for specific preoperative questions in specialized centers. Indirect contrast methods also had their limitations.
Okay, so what are the main imaging tools used now for planning?
MRI is becoming really important, specifically MR lymphangiography. It gives us great visualization of the lymphatic vessels themselves.
So you can see the anatomy clearly.
Exactly. It's useful both before surgery and to assess things afterwards. Plus, it's good for spotting related issues like vascular lymphatic malformations. It actually correlates well with lymphoscintigraphy findings.
Ah, okay.
Yeah, so MRI might be better for showing the fine details of the vessels, while lymphoscintigraphy often gives a better picture of the inguinal nodes, for example.
And lymphoscintigraphy is still a workhorse here, isn't it?
Oh, absolutely. It's fundamental for evaluating chronic lymphedema and planning the surgery. It doesn't just show anatomy, it assesses function. How well is the lymph actually moving?
Right, the transport.
Exactly. It maps the transport routes. We even have a measure, the lymphatic transport index, to sort of quantify the flow. Normal is under 10, roughly, while a score of 45 means basically no transport.
And you can use that index after surgery, too. to see if it worked.
Yes, it's really valuable for follow-up, like checking if a lymphatic graft is working. Standardization is key, though the dose of the tracer, patient activity during the scan all need to be consistent. So yeah, MRI for anatomy, lymphoscintigraphy for function, both are crucial.
Rutherford's also mentions using dye injection during the operation. How does that fit in?
Right, so intraoperatively, we can inject vital dyes like patent blue or isosulfan blue. It helps us actually see and identify the tiny lymphatic vessels we need to work on.
And what do you look for?
Normally, you'd see the dye flowing along the vessel, but in lymphedema, you might see what's called dermal backflow. The dye kind of pools in the skin because it can't drain properly. It's a visual sign of the pathology.
Any risks with the dye?
There is a small risk of allergic reaction, which is why it's typically done under general anesthesia.
Okay, makes sense. So you've got your imaging, you can see the problem. If the plan involves lymphatic grafting, taking healthy vessels from somewhere else, how do you make sure you don't cause lymphedema where you take the graft from?
That is a critical point. You have to assess the donor site, usually the thigh, very carefully beforehand, again using lymphoscintigraphy.
Should check the function there.
Precisely. The goal is to avoid causing secondary lymphedema in the donor leg. So you specifically need to avoid harvesting vessels from areas where the lymphatic system naturally narrows down, like around the knee and in the groin. You spare those convergence zones.
If you follow those rules.
Studies referenced in Rutherford's show that if you stick to these guidelines, you generally don't see problems like swelling or significant changes in the donor leg afterwards. Careful planning is key.
What about the overall risk for the patient undergoing these surgeries? Are they generally high-risk procedures?
For the subcutaneous procedures, like the grafting we just discussed, the risk is generally quite low. Lymphovenous shunting, which we'll get to, can often even be done under local anesthesia. The risk profile goes up a bit with the more extensive excisional surgeries. Sometimes those need to be done in stages. And of course, if you're dealing with tileless issues requiring abdominal or chest surgery, then standard preoperative risk assessment for major surgery applies.
Right. Let's move into the actual surgical techniques then. Autologous lymphatic grafting using the patient's own vessels.
Right.
When is this the go-to option, according to Rutherford's?
It's mainly indicated for secondary lymphedema where there's a known localized blockage. Think post-breast cancer treatment arm lymphedema or leg lymphedema after pelvic surgery or radiation.
So a clear obstruction point.
Yes. It can also be considered in some cases of primary lymphedema if it's caused by a localized issue, like a segment of missing or blocked vessels, perhaps unilateral pelvic or inguinal atresia.
And the timing. When should surgeons consider this?
Well, Rutherford suggests trying conservative therapy for at least 6 months first. Compression, massage, exercise.
Standard non-operative care.
Right. But if that's not working, the idea is to intervene relatively early. You want to ideally prevent those secondary tissue changes, the fibrosis, the fat deposition, that make the condition harder to treat later.
But you often see patients later.
Unfortunately, yes. There's often a pretty significant delay between when the swelling starts and when someone actually gets referred for surgical evaluation.
Okay, so can you walk us through the technique for the grafting itself, as described in the book?
Sure. So the grafts are usually taken from the inner thigh, the ventromedial lymphatic bundle. You can potentially find quite a few vessels there, maybe up to 16, but typically you'd harvest just 1 to 4 good ones.
And again, being careful around the knee and groin.
Absolutely crucial. You preserve the main drainage pathways. Then you can either do a free transfer, detach the vessels completely and replant them, or a transposition where they stay partially attached at one end.
How do you get the graft to the target area?
Often using suction catheters to gently create tunnels under the skin. Minimizes friction and trauma to the delicate graft. Then comes the really fine work, the anastomosis.
Connecting the vessels.
Exactly. Done under high magnification, using incredibly fine sutures, usually 10-0 absorbable. There's a specific no-turnover technique mentioned, where you just bring the cut ends together without folding the edges in.
Why is that important?
It minimizes damage to the inner lining, the intima, which reduces the risk of the connection narrowing or blocking off later. Keeping that anastomosis patent is key.
And the specific approach depends on the location, arm versus leg.
Right. For arm or neck issues, you might connect the grafts to lymph nodes in the neck. For leg edema, there's a technique called suprapubic transposition to bypass pelvic obstruction.
And post-op care. Anything special?
Generally, it involves standard wound care, compression, elevation. the usual postoperative management after subcutaneous surgery.
What about results? What can patients and surgeons expect? How do you measure success?
Success is measured in a few ways. Limb volume measurements are key. Is the arm or leg actually smaller? And then lymphoscintigraphy again, checking that transport index.
Can you actually see the graft working on imaging?
Directly visualizing the graft with traditional lymphangiography is tough, but studies do show improved lymphatic outflow on scintigraphy in a good percentage of patients. And sometimes with specialized imaging, you can see patent grafts.
And patient perspective.
Patients often report really significant improvements in their quality of life. Less heaviness, better function. There are long-term studies tracking patients for up to 8 years, showing sustained improvement in drainage that matches the volume reduction.
Are there common complications?
Potential issues include wound infections, fluid collections called lymphocysts, and more rarely things like DVT leading to leg swelling or venous bleeding during the dissection. But overall, it's shown good results in appropriate patients.
Okay. Rutherford also mentions other ways to directly reconstruct lymphatic pathways. What are those?
Yeah, briefly. There's free flap transfer, where you bring in tissue with its own blood supply and lymphatics and connect those lymphatics. Useful if there's also a soft tissue defect.
Like the Trevithick and Cormier technique.
Exactly, and others like Lionel. Then there are interposition vein grafts using a segment of vein to bridge a lymphatic gap. Ho et al., Mandel, Campisi have worked on that.
And lymph node transfer.
Right, free lymph node grafting, Becker and others. Transplanting lymph nodes to the affected area, the theory is they might act as little pumps or release growth factors like VEGF-C to stimulate new lymphatic vessel growth.
Does it work?
There's ongoing research. One potential downside mentioned is causing edema at the donor site where the nodes were taken. So various reconstructive options exist beyond just vessel grafting.
Let's switch gears to lymphovenous anastomosis, or LVA, connecting lymphatics to veins. When is this the preferred approach?
LVA is generally looked at for secondary lymphedema that's relatively recent, hasn't had lots of infections like cellulitis, and isn't responding well to conservative therapy.
So earlier stages.
Generally, yes. It tends to be less successful in late-stage disease where there's a lot of fibrosis and the lymphatic valves aren't working well anymore.
Are there patients who shouldn't have LVA?
A key contraindication is chronic venous insufficiency. If the venous pressure is high, connecting lymphatics to veins won't work well, the flow will be impeded. You need good venous outflow.
Makes sense. What's the preoperative workup for LVA?
Lymphoscintigraphy again, usually, to confirm you have dilated lymphatics below the groin but blockage higher up in the pelvis. Sometimes direct contrast lymphangiography might be used for really fine detail.
Any other imaging?
Indocyanine green, or ICG, fluorescence lymphography is increasingly used. It helps visualize the superficial lymphatics really well. And you'd also do non-invasive venous studies and maybe a CT scan to rule out any masses causing blockage.
Is there prep before surgery?
Often, yes. Patients might be undergoing for limb elevation and intermittent compression pumps to get as much swelling down as possible beforehand.
And the surgery itself?
Yeah.
How is LVA done, based on the descriptions?
For the leg, you'd make small incisions, maybe mid-thigh or near the groin, to find suitable superficial lymphatic vessels and small veins.
Do you use the dye again?
You try to, yes. Injecting vital dye helps identify the lymphatics, although if there's a lot of blockage, can be tricky. If they had contrast lymphangiography before, sometimes you can see the contrast-filled vessels.
And the connection.
It's microsurgery, very delicate. Typically an end-to-end anastomosis between the lymphatic and the vein using extremely fine sutures like 11-0 monofilament. There's also a technique called lymphatic cavernous implantation, basically sticking the lymphatic vessel into the vein.
What are the results like for LVA?
Studies cited show volume reduction in both primary and secondary lymphedema using these super microsurgical techniques. So it's another tool in the reconstructive toolbox.
Okay, let's move from reconstruction to resection, or debulking. Liposuction is mentioned. How does that apply here? It's not just cosmetic fat removal, right?
No, definitely not. In chronic lymphedema, it's not just fluid. Over time, you get hypertrophy of the adipose tissue, excess fat deposition. Liposuction in this context targets that excess adipose tissue.
How's it done?
Through small incisions, using vacuum aspiration, similar to cosmetic liposuction, but the goal is removing that specific lymphedema-associated fat. And crucially, postoperative compression therapy is essential, absolutely vital.
To maintain the result.
Exactly, to prevent the fluid from just reaccumulating in the space created. When combined with dedicated long-term compression, liposuction can lead to significant lasting volume reduction and improved quality of life.
Can it replace compression eventually?
Sometimes, perhaps. There's a suggestion that if you do lymphatic grafting first to improve drainage, then follow up with liposuction, it might reduce the lifelong need for intensive compression for some patients.
Interesting. Now, there's a much bigger resectional surgery described, the staged subcutaneous excision, the Miller technique. That sounds pretty major.
It is. It's a big operation, usually done in 2, sometimes 3 stages. You start medially on the inside of the limb.
What does it involve?
You make long incisions, lift skin flaps with just a thin layer of fat, and then remove the bulk of the thickened subcutaneous tissue underneath down to the muscle fascia. You have to be very careful to preserve major nerves like the sural nerve.
Then you remove excess skin.
Right. The deep fascia might be incised or partly removed too. Then excess skin is trimmed, drains are placed, and the flaps are closed. They emphasize really anchoring the skin flaps down, especially around the ankle and knee.
And then a second stage.
Months later, usually, you do the same thing on the lateral or outer side of the limb, again preserving nerves like branches of the peroneal nerve. It requires immobilization, elevation, compression, post-op.
What kind of outcomes does Rutherford's describe for this?
It's considered the most reliable operation for really significant debulking in advanced cases. It can produce marked, durable volume reduction, improve function, and reduce those recurrent cellulitis infections.
Similar results for primary and secondary?
Yes, the long-term results seem comparable, with relatively low rates of skin problems or late progression, according to the studies cited.
But there must be downsides.
Oh, definitely. It means long hospital stays, potential for poor wound healing, significant scarring is unavoidable, risk of nerve damage causing numbness or weakness, and you can still have some residual swelling, especially in the foot and ankle.
So it's reserved for severe cases.
Absolutely. It's generally for patients with really disabling lymphedema that just hasn't responded to anything else. It's a last resort debulking, essentially.
Okay. Lastly, let's touch on primary chylous disorders. What are these and how does surgery fit in?
Right, so chylous disorders are about the abnormal accumulation of chyle, that milky, fatty lymphatic fluid, usually because of congenital lymphatic issues or blockage of the main thoracic duct.
Where does the chyle accumulate?
It can be in the abdomen, causing chylocystitis, in the chest, causing chylothorax. It can leak into the gut, causing protein loss, or cause swelling elsewhere. Patients might present with leg edema, breathing problems, genital swelling, abdominal distension, things like that.
What's the surgical approach?
It depends on the location. For lower extremity or genital problems, surgery might involve finding and tying off leaky retroperitoneal lymph vessels.
And for chylous ascites?
If conservative measures like dietary changes fail, surgery is needed. Often you give the patient a fatty meal beforehand to make the leaky lymphatics easier to see during exploration. You then oversew the leaks or remove any chylous cysts. Sometimes, if it's localized to a bowel segment causing protein loss, bowel resection is needed.
Prognosis?
Better if you can find a clear fistula to close. Poorer if there's widespread fibrosis.
What about chylothorax chyle in the chest?
Surgery is often the best bet there. Usually involves pleurodesis, trying to make the lung stick to the chest wall, often combined with stripping the parietal pleura and prolonged suction.
Do you try to fix the leak directly?
Yes. During thoracotomy or VATS, again, ideally after a fatty meal, you look for the leaking thoracic duct or its branches and clip or oversew them, followed by the pleurodesis. Sometimes ligation of the thoracic duct is performed.
Is reconstructing the thoracic duct ever an option?
Rarely. If there's a blockage high up causing chyle reflex, a thoracic duct to azygos vein anastomosis might be considered to reroute flow. But it's complex, needs detailed preoperative imaging like lymphangiography, and often still requires dealing with other leaky mediastinal lymphatics. Success has been variable in the few reported cases.
Wow, okay. That covers a huge amount of ground on surgical management based on Rutherford's. So just to summarize the main surgical strategies we've discussed.
Broadly, we've looked at the 2 main categories. Reconstructive approaches, like autologous lymphatic grafting and lymphovenous anastomosis, which try to restore or improve lymphatic drainage.
And the excisional or debulking methods?
Exactly, like liposuction and the staged subcutaneous excision, which are focused more on reducing the physical volume of the affected limb when reconstruction isn't enough or possible.
And underpinning all of this is the absolute need for careful planning.
Absolutely critical. Thorough preoperative planning using the right imaging lymphoscintigraphy, MR lymphangiography, is essential for choosing the right procedure for the right patient and getting the best possible outcome.
And it's worth repeating the overall place of surgery here.
Yes. Always remember, conservative therapy, compression, exercise, skincare is the first line and the foundation of management. Surgery is for specific situations, specific patients, usually after a good trial of non-operative care hasn't achieved the desired results.
It definitely seems like a field that's still evolving, with techniques being refined.
It really is. There's ongoing work, refinement of microsurgical techniques, better imaging, better understanding of lymphatic physiology, all potentially leading to better outcomes, especially if we can intervene at the right time for the right patient.
Well, this has been a fantastic deep dive. It's clear that managing lymphedema surgically is complex, but the detailed guidance, like that in Rutherford's, provides a solid framework, and the continued advancements offer real hope. Thanks for joining us for this exploration on the deep dive.